Okay. Okay, sir. So,
all right.
I'm going live in going live in 3, 2, 1. Good evening, everybody. Good evening again. So there was some technical problem because of which there was some delay in this program, but now we are all set for this evening. So I welcome Dr. Sandeep Patwardhan again. He is a very well-known
Hi.
pediatric orthopedic surgeon from Sancheti Institute, Pune, and he's going to speak to us today on 10 commandments for tense femur nailing in pediatric fractures. Welcome, sir.
Good evening, Ashok. Thank you very much. So this talk comes to you from OrthoTV Online, courtesy iFix, International Fractures in Children Symposia, which we have been doing since many years. I'm sure you all do elastic nailing in femur in children since quite some time now. But even then, we find that there are a lot of errors and mistakes that people do make in their technique. So we've just put together a small presentation called 10 Commandments for TENS in the femur, which I'll go through. So the first commandment for elastic nailing in children for femur is, first is, thou shalt understand the concept of TENS. Now, when you say concept of TENS, most of the people ask us that they have been doing rush pins, Ender's nails for so many years. And they are elastic nails. So how come you are talking of TENS, and what is the different concept here? Is there some real conceptual difference, or it's just one new implant which has been brought into the market? If you look at the safety pin, actually it's just a stainless steel wire which has been coiled such that there is a spring action at one end and then there is a clasp at the other end. Now this stainless steel wire, when it is bent and secured at both the ends, it creates a tensile strength, right, which gives it the ability to hold up or pin objects. Similarly, an elastic nailing concept is a different concept compared to enders, where you just stack the canal with one nail, second nail, third nail. So that is a canal filling concept. Whereas this gives elastic stability, right? Because of tension created between the two bent ends of the stainless steel wire loop. So I'll just explain with an animation the same thing. So we have two pre-bent elastic nails which are inserted from either side from the dense metaphyseal bone. The bending of the nail is such that it is more than what the canal can easily accommodate, which creates an elastic recoil within the bone, and two nails of the equal diameter inserted from either side will then create a tension within the bone which stabilizes the fracture. So just look at this animation. The yellow here is the bone, this is the fracture, and you have this elastic nail with you, okay, the titanium elastic nail, which is the black line. Now you bend it to such an extent that when you put it in bone, it deforms bone, right? The bone actually deforms because the elastic nail is trying to straighten out. Now, if you put another nail which is pre-bent in the same amount from the opposite side, both of these elastic nails will create a sort of a spindle, and this spindle gives an excellent 6-point fixation. and that gives an elastic stability which under moving conditions creates sufficient early callus with no requirement of a plaster. So the concept of an elastic nailing system itself is different. It is not the same as putting a rush nail or not the same as putting endless nail. So it's technically a more superior biomechanical concept. The second commandment is thou shalt choose the correct indication, right? You know the tool, but your indication should also be right. So what is the correct indication for elastic nailing? Ashok, again the slides are stuck.
Again they are stuck?
Same, I can't progress.
Okay. I think
Okay, now we are in business. Can you see?
Yeah. You have to share the slide again.
No. I have to go back to share, no?
Yeah.
Okay.
In fact, I too have your slides. If you want, I can share.
Just wait, huh? Yeah. So the classical indications for elastic nailing would be a mid-diaphyseal fracture, right? Can you see this now, Ashok?
Yeah, I can. We can.
Yeah. Okay. So it's a mid-diaphyseal fracture which is transverse, short oblique, or a short spiral with minimal comminution. And the ideal indication is between a 5 to 12-year-old child who does not weigh more than 50 kilograms. Because more than 50 kilograms, the elastic nailing system has been found to be a little mechanically unstable and can cause bending or deformation. The classical indications are, as I said, transverse fractures in the middle third between 5 and 12 years, which can be nailed thus without any plaster support. And extended indications or relative indications are where you can use it in subtrochanteric or supracondylar fractures, but with a little modification of technique, which you will understand as you go along. Comminution actually is a contraindication, but we can bypass that by making some modifications, which I will talk about eventually. The third important commandment is thou shalt understand the nail and follow the proper bending principles. So what is this commandment? First, it starts with the nail size, right? The nail size, if it is too thin, it will pass very easily, but it will not give any stability. If you make it too thick, it is difficult to negotiate and becomes very stiff. So what should be the rule? The rule is that your nail should be 40% of the canal diameter at the isthmus. So the narrowest diameter should be measured and multiply that by 0.4, which is 40%, and each nail is 40%. So total, both of them comprise 80% of the canal diameter, which gives the perfect elastic stability. So measure the inner canal diameter, multiply it by 0.4. This is the choice of your nail. So you will choose a nail which is 40% inner diameter. How can you do that? Keep a nail on the patient's thigh, take a C-arm shoot, and make it put it from the entry, the metaphyseal region, to the intertrochanteric line, where is the final seating position, and see how much two nails occupy the canal. You should see a thin line of the canal outside the nail margins, which means that you are roughly right, and you should choose a nail accordingly. As a rule of thumb, the femur usually will take 3.5 or 4 mm. Tibia takes 2.5, 3 or 3.5. The humerus and forearm take between 2 and 3 millimeters. So this is a standard sizing which you will see in children between this age group. If you don't choose same size nails, so the second part of this choice of nail is you should always have same choice of nail. If you see there is a different size of nail, then the tensile forces are different. So the bone will bend on one side and create a deformity. So you must have a situation where both nails are equal diameter to balance out each other's forces. The next question is, how much do you bend? So again, the inner diameter comes to our rescue. So if the inner diameter is about 8 millimeters, then you will multiply it by 4, and that is your bend of the nail, right? So the apex of the bend. So your choice of the nail is 40%, and the apex of the bend is going to be 3 times the inner diameter, right? So you choose the nail 0.4 into D and bend the nail 3 into D. So 8 millimeter nail, the apex of the bend will be 24 millimeters, right? So just to show you that this is the straight nail, this is the apex of the bend. The apex of the bend should be 3 times the inner diameter. This is the amount of bend which is optimal for giving the optimal recoil for an elastic nail. The next point is, where should be the bend? So the apex of the bend should come exactly at the fracture side, right? If the apex of the bend is not at the fracture, you see that the spindle is not formed at the fracture. So what happens is that this creates relative instability, and that will not succeed. So the bending has to be exactly at the fracture apex. The height of the bend should be 3 times the diameter, and the size of the nail should be 0.4 into the diameter. So these are the nail and bending principles which you should know, so that your nail spindle is perfect. An example here, the artery forceps is showing you the apex where the bend should be, and then you bend it 3 times the inner diameter. That is how you choose it, and then the apex is bent exactly there. This is the nail chosen. Now this nail should be bent equally on both sides of the apex. The rest of the nail need not be bent. So it is not that you have to bend the whole nail. The rest of the nail can be straight and it need not be bent, but equal bend on both sides depending on the apex of the bend. Symmetrical bending can be achieved with the use of these wire benders or plate benders if you have available, or there is a handheld tool which you can use to bend the nails. But make sure that you are bending symmetrically, right? So these are examples. Now the medial nail is always a little longer because it goes to the neck region and it is bent on a longer arc of diameter. Okay, just remember that the medial nail bending is usually more because it's bent more because it goes in more, right? Second, you must have smooth bending on either side. So bending should be starting from the apex and proceed symmetrically on either side. Don't bend at the ends too much and very little in the middle, right? So bend at the apex first and then smooth curves on either side so that it forms a uniform arc, right? Uniform bending will give you excellent recoil. The fourth commandment is that don't be very conservative with your entry points. Thou shalt make an adequate entry so that you don't struggle. The medial entry should be about 2 finger breadths proximal to the superior pole of the patella. On either side, you can have a symmetric entry point. You can pass a K-wire and drill over it, right? Something like this. So you enter with a straight awl and then make an adequate channel with a curved awl to enter the canal adequately, right? From both the sides. So a symmetrical entry point about 2 finger breadths proximal to the physis, which lies at the superior pole of the patella as a surface marking guide. Now, if you don't do that, if the entry point is not right, you can end up having a nail which rotates or is placed too anterior, and that irritates the synovial pouch. So irritation of the suprapatellar pouch, nail which backs out, if it is not adequate, may cause irritation of ligament. Finally, the nail should be sufficiently away from the growth plate. Now see this nail, this has been placed, this is an ender's nail, it has not followed any of the principles. A single nail has been passed, which has created a valgus deformity in the fracture side, plus the tip of the nail sat on the physis and irritated the physis, which got infected, and you can see a growth arrest there, plus a femoral inefficient valgus. So both the principles have been violated. There is no symmetrical nail balancing force here, and the nail has been inserted too close to the physis. So these things should be avoided. Another example where somebody has put ender's nails again, but the tip is lying on the physis, and this has worked like a growth modulation tool. It has actually reduced the growth on one side because the nail tip obstructed the pericontial blood supply to the physis here and resulted in a valgus deformity. Right? So you can get growth related issues if you don't put the nail correctly. Finally, distal entry is always preferred because if you put the nail from proximal side here, you can see two enters nails being passed here. They have gone through the pyriform fossa, which puts the head at risk because the lateral cervical ascending artery comes from here. You will cause avian or you will damage the physis here. And in this patient, what happened is it damaged the physis, it stopped growing and ended up with severe genuine. Naveen, you can see me. Okay, Ikra?
Yeah, we can see you.
Hello.
Yeah, we are online.
Yeah, you can. Yeah, but my screen is still.
Okay, we'll wait for
Sorry
it.
about that glitch again. Technology can sometimes kill you. So I'm waiting for this slide to open. I've put it on slide share and I've put it on full screen, but that full screen is not opening.
Okay.
It's taking time. Yeah. Okay, can you see now?
Yeah, it's perfect.
Okay, so the fifth commandment that I wanted to speak about was how do you advance the nail in the canal. So the commandment 5 is thou shall advance the nail correctly. So when you enter the entry point where you have made the adequate entry point, your nail should go in the direction of the curve, right? So this is how you enter rather than struggling by trying to push it in directly. Go with the curve into the canal first, then turn it around 180 degrees to face the medullary canal. Then you advance it slowly so that it bounces off the opposite cortex. Always use two chucks and never hammer the nail. If you are requiring hammering instead of your hand motion, probably something is going wrong. Okay, you will either perforate the cortex or then your nail, your entry point is not adequate. You have not entered the canal at all. Right? So you should be able to pass the nail on either side, use both two chucks and go simultaneously. Never go one nail into the fracture site and across the fracture. Bring it to the fracture site. See, this is an example of snaking due to severe rotation. Sometimes you keep on rotating the nail in an attempt and then you get a spiraling like this. This is called snaking. And this is not healthy because it takes away the spindle and creates instability. The sixth commandment is that thou shall use proper reduction maneuvers to get your reduction before you pass the nail across. People who use fracture table can use traction and distract the fracture a little bit so that it is easy to pass the nail. But sometimes it becomes difficult to put a small child on a fracture table. The fracture tables that are available are usually adult fracture tables. And I personally don't use a fracture table. I use a radiolucent table on which we use manual traction with a small pillow or a small bolster under the thigh so that the anterior bow of the femur is restored. Okay, and with that you can also use a reduction tool. This is called the F tool or the reduction tool, with which you can maneuver the fragment into procurvatum, recurvatum or varus or valgus as you get your reduction. After that, pass always the first nail that easily goes into the across the fracture. Sometimes you can use a joystick maneuver, use a pin. You can see this pin being used to push the fragment opposite side so that it creates an appropriate angle for the nail to enter the proximal fragment. Right? Use that hockey stick bend so that you can maneuver the tip into the opposite diameter canal and engage it before you turn it around. So always use these small tips and tricks. Use a K-wire, use the hockey stick bend, use the F tool and get your reduction. Get one nail across first before you pass the second nail. The seventh commandment is that thou shalt maintain the length of the femur at all times, which is why we said that the comminuted fractures are not such a good idea. Now see this fracture. You have a long spiral here with some combination and 3.5 mm nails have been passed. The nail placement intertrochanteric is good, but the nature of the fracture is such that it collapses. So this is not a length stable fracture. Transverse fractures, short oblique fractures are length stable. And over a period of time, because of the collapse, you see that the nails have backed out or protruded. So long spirals, there is a chance that you may end up with backing of the nails because this is not length stable configuration. So what can be done for this? AO provides these end caps. So these are threaded diameter specific caps which can be used to plug or block your nail at the entry point so that it doesn't back off, and it gives a more secure fixation like an interlocking screw so that the length is maintained. So this is an example of a long spiral fracture here. Again, use of two nails, a nice spindle here, but perfect use of end cap so that this cannot back off. Because it cannot back off, then the length is maintained and it goes on to a satisfactory callus end. So end caps will give you length stability. Remember that. If you don't have an end cap, what I prefer to do is in this particular comminuted fracture, you can see we pass the nails and we maintain length with the use of an external fixator. So a couple of pins here and couple of pins in the distal fragment. All that comminuted fragments have been bypassed using elastic nails and put the fixator so that there is no collapse. In about 4 weeks, you can see that there is callus formation. The fixator comes off, your length is maintained once the callus starts hardening. And then the nails take over as internal splints. So completely closed procedure, even in bad comminuted fractures, we have been able to do closed nailing, closed external fixator, use the biology for a biological healing, protect it with a brace later, and this is how it healed and remodeled beautifully. That is at implant removal with full range of motion. So it's not that the fixator created any stiffness or muscle fibrosis. It's a temporary fixator. You can use even a Jess fixator and keep it on for 3 to 4 weeks just to maintain length so that callus forms, and then you remove the fixator and go to the nail as a stability tool. Commandment 8 is thou shalt seat the nails flush. As an orthopedic surgeon, we have this tendency of bending the KO as right angle and resist that temptation in elastic nails. Because what happens is that in elastic nailing, we are not supposed to bend the nails at right angles because we'll end up creating synovial irritation. Ashok, we are stuck again.
Okay.
Slide not advancing.
Okay, just a minute, sir.
Yeah, okay. Now, okay, we went ahead.
Yeah.
Okay, so you can see here, if you don't seat the nails flush, you get recurrent effusions like these. Okay, end of the nail can cause soft tissue irritation, especially if the nail is pointing anteriorly or if it rotates anteriorly secondarily. So right angle bend of the nail is a very bad idea. You should have the nail flush with the cortex. And this is a special tool available in the set, which is the final seating tamp, by which you can push the nail in such that 1 centimeter remains parallel to the cortex here, right? So it doesn't really sink it in, it remains outside. About a centimeter is available to you outside, but flush with the cortex. Don't make a right angle curve. 9th commandment is thou shalt check rotations before final seating. Now see this X-ray. A transverse fracture which has been fixed with elastic nails. Satisfactory healing is seen, but the mother says that she is not walking well. She walks crooked. And when you examine the child, you find that there is you can see this external rotation on this side and opposite side where the surgery is being done, too much of internal rotation and less of external rotation. So what has happened is that, but in a transverse fracture, you can end up having 45 to 90-degree mal rotation and you will never make out on the CR because the fracture alignment will look perfect. So it's always important at the end of the surgery to check rotations, especially with transverse fractures, so that you make out that there is no mal rotation which can cause a problem. If there is a mal rotation, you will need to withdraw the nail, turn the fragment around. Now X-ray, if you see, this shows AP here and lateral on the proximal side. This is mal rotated by 90 degrees. And finally, removal of implant is a big issue because most of the times the parents or the patient wants that implant removed. You should remove implant in the femur after 6 months, preferably less than 18 months. Forearm fractures, you can remove it later because it takes longer to heal. When you remove the nail, as I said, the nail has to be flush a centimeter out. Use a small periosteum elevator. Get under the nail so that you can hold it with a wrench or a plier. Special extractors are available in the AO set which have a sharp fin against which you can hammer, and these are locking clamps. If you don't have this, what I prefer to do, I'll just show you. Ashok, again, can you help me with the slide?
Yeah.
I'm not able to go ahead. Yeah. So I'll just show you this small video here. Okay, we have to go back.
Okay.
Now we are going in front.
Yeah.
Yeah. So this is a small video which I wanted you to see. Everybody in their hospital will have a hollow mill, right? So I'll just show you what I do with the hollow mill. Right? You can see the nail tip here. This is a femur nail that I am removing. That's the nail tip flush with the cortex. So just insert a hollow mill, bend the nail 90 degrees. Once you bend the nail, your plier can grip it very well. Okay? And then you can backhammer it. Because it's a small area there and it's very difficult to hold a nail. It becomes so easy. Right? I'll run this again for you. The nail 1 centimeter is usually left outside flush with the cortex. You can see that here. After exposing it, just pass a small hollow mill around that, right? Against the cortex, turn it 90 degrees. You will be able to do that. And then you will be able to hold it with a plier at 90 degrees and then backhammer it. Sometimes holding it with the tip becomes very, very difficult and it keeps on slipping. So this is a small tip that you can do. And final, this is my commandment. If you're not comfortable or confident or not trained in using elastic nails, do what is comfortable for you, including plating or spica. It's not mandatory that every child needs to. A badly fixed fracture is worse than conservative treatment. So conservative treatment always works provided you maintain length, rotation, right, and alignment. Length, alignment, rotation, LAR. Remember those. But for a 5-year-old to 12-year-old less than 50 kilograms, ideal indication, elastic nails today are gold standard and they work beautifully well. And with this, I would like to welcome you to the iFix 2018 Operative Symposium at Ganga Hospital in Coimbatore, where we have Dr. Sheetal Parekh, Dr. Alvin Crawford, and James V as foreign faculty. Along with all of us, we will be doing live surgery on children's fractures and teach you more about everything in children's fractures through iFix, which is International Fractures in Children Symposium. The more you see, the better you learn. And signing off from my end, thank you, Ashok, for this opportunity.
Thank you, sir.
Happy to talk and take any questions if any.
Yes, sir. There are quite a few questions now with
Ashok?
us.
Are you around?
So, yeah. Yes, sir.
Could you hear me?
Yeah, I can hear you perfectly. So,
okay. So
there are quite a few questions here with us. So
Okay.
I start shooting them. So first one is, what is your post-op protocol, and what do the factors that affect the post-op protocol?
Okay, so post-op protocol depends on two things. One is how much stability could you achieve on table with your fixation, right?
Right.
So if you have a transverse or a short oblique fracture and you have a perfect spindle at the apex, your metaphyseal fit of the nail entry points are good, your intertrochanteric seating points are good, right? So you have a good elastic stability on table. I do not give any immobilization at all. We give a long leg knee brace for pain relief, and after 48 hours, first wound check, we start bedside knee bending exercises. Active SLR is not recommended, but non-weight bearing crutch walking can be started on the 3rd day immediately, and knee bending exercises by the bed should be started. In about 15 days, when they come back for suture removal, we start toe touch. At 4 weeks, we take an X-ray. If I see adequately sufficient callus on the first post-op X-ray at a month, we will increase weight bearing to about 40 to 50%. As the weight bearing increases, the callus starts maturing, and most of my kids in transverse stable fractures with good fixation will be off walker at the end of 6 weeks and will be full weight bearing. Sports, I allow them after 3 months, that is 12 weeks, when the callus is completely consolidated. That is my post-op protocol. If there is a heavy child, or if there is a comminution, or if it's a spiral fracture which has a tendency to back off, length unstable, then probably I will give a cylindrical cast for about 2 to 3 weeks till callus forms as an additional immobilizer. And only then I will mobilize the child. So that is my protocol for the.
Okay. The second question is, what is your lowest and the highest age as well as weight cutoff points for elastic
Right.
nailings versus
Yeah.
compared to submuscular plating if you're doing them?
Right. So I prefer nailing to plating because it's easy and equally effective and more biological and
Right.
easier to remove the implant also compared to a plate.
Right.
But the theoretical age weight cutoff is 49 kilograms if you read the literature. But I have done it in old, heavier patients also. But you must make sure that you immobilize them additionally, because there will be a tendency for the muscular forces to create a coronal plane deformity, either mostly varus, because the system is not strong enough. So if you have a patient who is 60 kilograms or 65 kilograms, then it is better to use a adolescent titanium nail, which is available with a few companies, which is a trochanteric entry locked nail in diameters of 8, 8.5, so that an adolescent femur will accommodate that. However, I have the youngest I have done elastic nailing is about 4 years. I don't prefer to do it less than 4 years because most of them get all right with a hip spica. The only problem is you have to counsel the family a little more that you don't really need surgery and we can avoid two surgeries, one of putting implant, one of taking it out. So conservative works very well and they can tolerate a spica easily. The older children, 5 and above, preferably elastic nails. And I have done till about 55-60 kg, but we protect them additionally.
Any experience with submuscular plating in this pediatric
So
fracture?
submuscular comminuted fractures and spiral fractures are indications for submuscular plates. Second indication is junctional fractures. If you have a subtrochanteric fracture or if you have a supracondylar fracture where elastic nails standalone are not stable enough. Right? So you can slide a submuscular plate and lock it, but again you need a very long plate for that. The span is quite long and you will end up crossing the physis with your plate, and in that situation you need to get rid of remove those epiphyseal screws early, or they will act like a growth modulation and create a coronal plane deformity. So we have used metaphyseal lock plates, submuscular or even open sometimes in comminuted, supracondylar as well as metadiaphyseal junctional fractures if it's combination. But then we have to remove the implant early and remove those epiphyseal screws especially, and try not to cross the epiphyseal plate because they will act like growth modulation to the rate plates, create deformities. So I'm not a big fan of plates.
Okay. So there was a similar question.
I would rather use an elastic nail and a fixator because it is completely closed and makes it completely biological.
Okay. So there was a related question by Dr. Pankaj Rane about any special precaution for spiral subtrochanteric fractures when doing tense nail.
Right. So what happens with subtrochanteric spirals is that any spiral you have to understand can be length unstable. Second thing is, the higher you go with the fracture, there is dense metaphyseal bone in the intertrochanteric and subtrochanteric area. So your spindle is not really creating any kind of tension effect like it creates in the diaphysis. So the system is not stable. You can still use the nail as an aligner. It is semi-stable, but you should protect this with a Thomas splint till you see callus. So see the soft callus so that collapse doesn't happen, or then use end caps. These are the two recommendations. Also, in subtrochanteric fractures, because of muscular forces, there is a tendency for the proximal fragment to externally rotate. So you will end up creating malrotation. So you have to use a shank spin, derotate that fragment before you pass the nail in the proximal fragment.
Right. So this flexible nailing have been around starting from Nancy's nail, Ender's nail, and now with
1983 onwards.
So what is the difference between the earlier flexible nails and now with the titanium nails?
So the earlier flexible nails or the ender's nails basically are pre-bent nails. They have a pre-bent curve to them, which is not matching to the fracture site, right? So
Right.
it is a general pre-bent nail with an eye in the end, which is stainless steel, which you just hammer in. And if you see, if you're working in Gujarat area, they are very fond of ender's nailing. They will put multiple nails only from one side. Okay, they are not using any balanced forces or anything. They will just stack nails, one nail, second nail, third nail, till the whole canal gets jammed. Right? Not that it doesn't work, but the principle is different.
Okay.
Here you are having a system which, because of the titanium metal itself, has got an elastic recoil value. Okay, it's a special alloy, titanium vanadium alloy, which gives it that recoil value. And you should have a good quality nail for that, because some companies use pure titanium, which is highly malleable, which actually bends in your hand. It has no recoil. So that is useless. You must have the right alloy with you, which recoils. You should be able to bend, and you release it, it springs.
Right.
That kind of a nail, you are, as a surgeon, creating a perfect spindle by bending it at the apex. It's not a pre-bent nail. It's a standard size nail. You are the one who chooses where to bend, how much to bend, which diameter you will use, and create a spindle or a spring action situation in the intramedullary canal. So that is the difference. And rush nails are simple, straight aligning nails, which have to be protected additionally with plasters.
So there are few companies that offer stainless steel flexible nail versus the titanium nail. Like you already mentioned, there
Right,
is a difference in
right,
elasticity. So
right.
is the principle different there then?
So there are companies which offer stainless steel elastic nails where the material properties will be different. The concept does not change. The concept of an elastic nail was made originally. If you see, even the earlier non-stick nails were stainless steel, but the recoil strength and the recoil is different.
Okay.
Principle remaining same, material properties are different. I haven't used stainless steel nails. A lot of centers in America are using stainless steel nails and claim equal results. So if they're available, and I would like to use them, but I haven't used a stainless steel nail yet.
Okay.
Elastic.
Okay. So what is your experience with complications in this tense nailing of femur fracture?
Right. So complications I already showed you. The thing is that when your entry points are not perfect or adequate, there is a risk of creating growth arrest by leaving the nail out too long on the fascial plate, or your entry is too low, creating a damage to the fascial plate when you're entering, not entering the canal properly and hammering without actually entering the nail correctly into the canal, causing perforation on the opposite side,
Right.
snaking of the nail or spiraling because you just kept on rotating like a corkscrew. That is not to be done.
Right.
Bending the nail at right angles, creating recurrent knee effusions or stiffness in the knee. Wrong indication where you shouldn't have used a nail, or you did not use an additional fixator, creating backing off of the nail, collapse, shortening. All these problems are there, complications.
Okay.
Or loading them too early without understanding, and then the system bends. So if you follow the perfect indication, it's a superb tool.
Okay. Another question was, do you often face this issue of limb length discrepancy with this kind of nailing?
Limb length discrepancy will not happen if you are having a stable construct and it is a length stable. So length stability is the key. That's what I said in the beginning.
Right.
Indications. What are the indications? Length stable, short oblique or transverse fractures with minimal combination.
Okay.
Extended indications, you must modify the technique to suit the requirement. Now, I said initially that you will use same diameter nails, right?
Right.
But if there is medial comminution, right, there is a tendency to varus. So the lateral nail, I can use thicker diameter or bend it more to counter the forces which are going to cause a collapse. So you can play around with the principles of bending and the diameters so that you negate the effects of the stress. So once you understand the correct principles, then you will be able to play around with them to suit your requirement.
Right. There is another question by Dr. Ramchandra Reddy. This is a general question about femur fracture in less than 5-year-old age child.
Okay.
So when to apply the hip spica, whether to apply immediately or whether they should wait for
Right.
some period of time?
So sometime we should do a seminar on pediatric femoral fractures. But
Yeah.
to answer that question, in a small child less than 5 years, there is something known as the telescope test.
Mhm.
When you take the child under anesthesia for a spica, you should do a push-pull, and if the fragment overlap exceeds 1 inch on table,
Okay.
that is 3 centimeters, there is a chance of ending up with shortening if you do immediate spica. So if the push-pull test or the telescope test exceeds an inch, you would put the child in fixed traction in a Thomas's splint till soft callus is formed. So give traction for about 2 weeks till soft callus forms, so that there is no shortening that will happen. Incorrect alignment. You don't need accurate reduction, you just need alignment.
Right.
And you need traction to maintain length. Once callus is formed, it will not collapse, and then you convert it into a spica, which is more comfortable rather than a Thomas's splint. So immediate spica for length stable fractures where telescope test is negative or overlap is less than 2 centimeters.
Right. There is
Correct
another.
the alignment and rotation. Don't bother about good X-ray.
Okay. So there is another question by Dr. Rohan Parwani. He is asking, are there any indications for antegrade entry of tense nails?
Yes. So if you have a supracondylar fracture or a metadiaphyseal lower third fracture, then you will use the divergent or umbrella principle. This is not creating a spindle, but you will then enter at the insertion or the entry point of this nail is just below the tip, the flare of the trochanter, not the tip, from where you use your DHS guide wire, which goes into the neck.
Right.
So just at that spot and a little posterolateral to it, 2 entry points, both on the lateral side. But when you make these entry points and the nail is bent in a C-shaped fashion, one of the nails you must twist it to 180 degrees to create an S bend, so that when the nail goes into metaphysis, it is divergent. So one nail will be a C bend, one nail will be an S bend.
Okay.
So that it is a divergent fixation. Also, remember that it is not a perfect stable fixation. So make sure that you will give a long leg plaster or some kind of support, so that you don't end up with a complication.
Right. Right. I think those were all the questions that I got from our viewers. And
Okay.
again, thank you very much for this great talk. So, and we'll probably.
I'm sorry about the technology issue. I think there was something wrong with my laptop or the connection where we kept on going offline.
Yeah. Yeah, but we could cover the entire talk in parts.
Yeah, I think we could complete it at least. I think
Yeah.
if you record it, you need to edit it.
Okay.
And I would again invite all those who are watching to come for iFix. And in TraumaCon this time we have one full day called TraumaCon iFix on Wednesday, 15th August.
Okay.
You can register for it separately. You don't need to register for TraumaCon entire. For 2,500 rupees, you can register for iFix TraumaCon day, which is one whole day on children's fractures. All most of the things will be covered from 8:30 in the morning to 5 o'clock in the evening on day 1 of TraumaCon. Okay. And from the next day, 16th, 17th onwards, we have operative Ganga iFix at Coimbatore. Okay. So people can contact you for registration.
Yeah. Just this last question coming up about the removal of the nail. If the length is insufficient, or if the patient presents late and the tip of the length is inside the canal, how to retrieve it?
So, so I'll tell you a practical misconception. When you insert the titanium elastic nail, it is from the metaphysis, right?
Right.
The epiphyseal plate is below your entry point.
Right.
So all the growth adds bone inferiorly. So your skin incision will be at a different level. But the nail really does never migrate into the canal. So it is a misconception that the nail, because it has moved up on X-ray, it has gone into the canal. It has never gone into the canal. It is still on the lateral cortex, engaged by the metaphyseal bone. Okay. The growth plate has moved away. So your skin incision will be higher. But you will always find the nail on the cortex.
Right.
right? So you just dig around that area, like I showed you, put a periosteum under it to clear space,
Right.
put that hollow mill and just bend it right angle and back hammer it, because holding it with a plier, it keeps on slipping because it's a smooth nail, there are no serrations, and the tools sometimes are not adequately good enough to grip that nail. So the best way is to bend it to 90 degrees, which I showed you earlier.
Right.
Yeah, if you want me to share that slide again?
Yeah, we can. Just a minute.
Oh,
Yeah.
right. So is it sharing now?
Yeah, it is. You can
Yeah.
start
So
the.
I'll show you this again. Yeah, I can start the video. Yeah. 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 You can see the nail here.
Right.
So yeah. So see that hollow mill, and so supposing the nail has gone in, it will be somewhere here.
Right.
Can you see that cursor?
Right. Yeah, we
Right.
can.
So instead of here, the skin incision will be here, but the nail will be on the cortex. It doesn't go intramedullary unless your nail never was seated correctly in the metaphyseal bone. It had already gone intramedullary. You had hammered it totally inside.
So, in your experience, anytime you
That
were.
does happen sometimes.
Yeah.
I have retrieved a intramedullary gone nail somewhere. He was operated in Middle East.
Okay.
And they had made an entry point from the anterior suprapatellar area.
Okay.
So he had a severe irritation of the suprapatellar synovitis because the entry point was through the suprapatellar fossa. The nail was something like this from front.
Okay.
Which was quite a disaster. So we had to retrieve it by making a big hole and a linear osteotomy to pick up the nail from inside. So that's really a disaster.
Okay. Okay, sir. I think we'll end this webinar on that note.
Okay.
Thank you very much.
Thank you. Thank you, Ashok. Good night.
Thank you, sir.